Hey, listeners, and welcome to our podcast. We are Doctor of Nursing practice students with the University of Florida who are passionate about empowering patients and advancing healthcare. My name is Anna Scott, a board certified family nurse practitioner, and I have worked in primary care for over 2 years.
Hi, everyone. My name is Jennifer Hubert. I'm a licensed clinical social worker and a registered nurse specializing in psychiatric mental health. I've been in the social work field for about 10 years and a registered nurse for 5. Currently, I work as a mental health therapist and I assist individuals that struggle with psychiatric disorders with achieving psychological and physical wellness.
Hi everyone, I'm Mercy Givergis. I'm also a board certified family nurse practitioner with over 7 years of experience as a nurse practitioner and 10 years of experience as a registered nurse. In total, about 17 years of experience in healthcare. Currently, I work at Lakeland Volunteers in Medicine, providing comprehensive care to undeserved populations, managing both acute and chronic conditions while promoting health and wellness. Today, we are diving into a critical topic that affects so many lives: polypharmacy and its impact on hypertension.
Yes, and today we are excited to introduce you to Emily McCarthy, a fellow family nurse practitioner that will give us her perspective on polypharmacy and hypertension in primary care, specifically in geriatrics. So thanks for being with us today, Emily.
You're welcome. Happy to be here. Thank you for having me.
Of course, now we're going to learn a little more about you and your practice, but our goal here today is to unpack the challenges, explore solutions, and provide practical insights to help navigate this complex issue. So let's get started.
So, Emily, can you introduce yourself and share a little bit about your experience as a nurse practitioner?
Yeah, I've been a registered nurse for it was 12 years, 13 years, and I've been a nurse practitioner for 2 years. I primarily see geriatric and elderly patients in assisted living, long-term care, and acute rehab facilities.
That's awesome. Well, let me ask you, why do you think polypharmacy is a significant issue in hypertension management, but more so primarily in primary care?
My honest opinion about polypharmacy is I think that the American healthcare system is designed to be run with or controlled by pharmaceuticals. I don't think that we promote disease prevention or focus on curative measures or healthy lifestyle habits. I think that we just use polypharmacy to manage and medicate.
Yeah, that is a really big issue that we have. Thank you for sharing that. And also, studies indicate that approximately over 50% of older adults are taking more than one medication that is not clinically indicated. So, what are some of the most common medication combinations you see with hypertensive patients?
Oh gosh, I see a lot of ACEs, ARBs, diuretics, and beta blockers primarily.
Interesting. Okay. And at what point do you think prescribing multiple antihypertensive medications becomes problematic?
It becomes problematic when patients don't know, they're not educated well on safety and efficacy. I think that a lot of elderly patients are prone to dehydration, which is just it's made worse when they're on the diuretics and leads to acute kidney injuries, UTIs, falls, altered mental status.
I agree. I think some of the most common potential risks that I see in my practice involving polypharmacy and hypertensive patients are things like drug interactions, adverse effects, and patient compliance issues. For instance, certain medications, when combined, can cause dangerous interactions that either increase the risk of side effects or reduce the efficacy of treatment. For example, combining ACE inhibitors with potassium sparing diuretics can lead to hyperkalemia, which can be life threatening. And additionally, adverse effects like orthostatic hypotension or dizziness can often be compounded when multiple antihypertensive drugs are prescribed, especially in older adults. Patient compliance has also become a significant issue as patients struggle to manage multiple medications, which often leads to missed doses, confusion, or even discontinuation of medications altogether. So it's kind of crucial that we work to simplify regimens and educate patients to like reduce these
Yeah,
risks.
well said.
I notice in older women, usually around 60 years and up, who are hyponatremic, who may be on hypertension meds such as thiazide or loop diuretics, just like you mentioned, Emily. And unless the patient or nursing staff are monitoring their blood pressure regularly, their symptoms can be hard to decipher, whether headaches are from low sodium or from hypertension. Ordering labs are sometimes easier said than done. I think Emily can agree, especially in facilities. Plus, if they're on anti-epileptic medications such as Keppra, carbamazepine, or certain mood-altering drugs such as lamotrigine or SSRIs, this can also cause worsening of hyponatremia, which can also cause worst-case scenario delirium or seizures requiring acute care.
It is common to see electrolyte imbalances in the geriatric population, but it can be harder to pinpoint if you don't obtain a thorough history or get vitals from nurses to ensure blood pressure control. It's also important to review the med list frequently to ensure a medication hasn't been added or taken away due to a recent hospital discharge, specialty follow-up, or something like that.
And so I've gone ahead and looked at, so the next question is, what are some of the solutions? So I looked at some evidence-based practices and outlined some guidelines and best practices for safely managing multiple antihypertensive medications. So some of the tools that I found was the no tears tool. This is used to review medications and help with medication reconciliation. Another tool that I found was the hyperpharmacotherapy assessment tool, which delineates 6 goals. And it's mainly to help prescribers reduce polypharmacy in long-term care facilities. Another one is the Beers criteria, which is widely used to provide an evidence-based approach to improve prescription drug selection for providers. The next is the screening tool of older persons, potentially inappropriate prescriptions. It follows the acronym STOPP, STOP, which identifies drug interactions, duplicate therapies, and an inappropriate prescription medication in older adults. The last 2 is the medication appropriate index, which provides a scoring method and shows a positive correlation between high scores and drug-related hospital admissions. And then the last one is the anticholinergic drug scale, which provides 117 medications that have anticholinergic effects affecting cognition, functional activity, falls, hospital readmissions, and mortality. So Emily, how do you approach deprescribing or simplifying medication regimens for hypertensive patients?
For my patients, I mean, it's a little different for me in facilities because I have access to continuous monitoring. I can do labs anytime I suspect there's a problem. But when they're being discharged, I have to really focus on making sure they're being discharged on the appropriate medications with the right follow-ups. So I just make sure the patients are educated continuously. I monitor them while they're under my care to ensure that the medications are effective. If I can take any away, I'm able to do that. So they're discharged on the least amount of meds.
Emily, do you think or do you agree that there are specific patient populations where polypharmacy poses an even greater risk, like, for example, populations like the elderly, those with kidney disease, or patients with multiple comorbidities may be at higher risk? What are your thoughts on that?
I agree. I think all the above, the elderly, people with chronic kidney disease, and comorbidities are all at risk of polypharmacy.
I'm not sure if this is something you encounter in your facility, but do you think patient factors such as lifestyle adherence and socioeconomic status impact medication management?
Absolutely, I do. I think that lifestyle modifications would be the most beneficial for a lot of people. That's what I said earlier too, is I don't think that we as healthcare providers are really able to encourage that as much as we are expected to encourage medications.
That makes sense, as patients and facilities often receive medications directly administered by healthcare providers, which can mitigate some of the risks associated with polypharmacy. However, even those settings, factors like medication errors, interactions, and the patient's ability to tolerate multiple medications can still be challenges. Socioeconomic status can also impact a patient's access to follow-up care and resources, which may affect their ability to manage complex medication regimens, even if the medication are administered in the facility. Do you find that there is a role in patient education and preventing the complications of polypharmacy where you work?
I do, because the patients who are on short-term rehab who are being discharged, oftentimes they've been prescribed new medications from the hospital if they're in cardiac rehab or whatnot. So they do require continuous education daily by nursing so that they really have a full understanding when they're discharged on the safety and efficacy of medications, as well as patients who are long-term care need to be educated so they are aware of what symptoms and conditions that they should report to nursing staff.
Okay. I can say since I see patients in the office, in my practice, without patient education, I think most patients would be lost. The Journal of Royal Society of Medicine actually say that patients may forget anywhere from 40 to 80% of patient education right after the appointment. And that's a lot to forget. So I find that if I write down patient instructions, such as what meds to look for, how to take them, what red flags to look for as far as side effects, it's helpful for the patient because they have something to reference back to.
I completely agree with you, Anna. And in my clinic, patient education is essential to ensuring that our patients can properly manage their conditions. I provide patients with a printed medication list that includes the name of their medication, dosages, and instructions on how to take them. For patients who may be more uneducated or having difficulty understanding the instructions, I encourage them to write it or write important notes on the medication bottle for them to remember. Additionally, I also make sure to educate not only the patient but also their family members so that they can provide support at home and help reinforce the instructions. This approach has helped improve adherence and gives patients and their families a clear reference to guide them in managing their health.
Patient education is very important, Mercy, and I'm glad that you provide that for your patients that you see. So, Emily, do you run into any issues with insurance and cost considerations that affect your choice of antihypertensive medications in facilities?
I do, and it doesn't so much go back on the patient's own health insurance, but what the facilities will pay for. So the pharmacy from the facility often will send a letter with an alternative medication because one is too expensive. They recommend substituting it for another, which can cause problems when patients are discharged because maybe their personal insurance will pay for it where the facility won't, or vice versa.
Okay, I didn't even think about that as an issue, so I'm glad they kind of help, but sometimes it's easier said than done.
Yeah.
I'd have to say I don't have too much of an issue with cost and insurance coverage in the clinic as most are insured, but I do have the ability to see if someone's self-pay. So if someone's blood pressure is significantly elevated and I know that they're self-pay, instead of choosing something like Valsartan 80 milligrams that has better 24-hour coverage, it may cost around $100 for a 30-day supply. I may choose Losartan 50 milligrams once or twice a day instead, which may cost between $15 and $30 depending on the pharmacy they choose. And to expand on polypharmacy, I make sure that their GFR is above a certain number to ensure I'm not going to worsen any CKD. And I also make sure to tell them about potential side effects such as dependent edema, especially if they're already on a calcium channel blocker or if they have CHF.
In my practice, we often work with uninsured patients, and the cost can be a significant concern when prescribing medication. Similar to your approach, Anna, I consider more affordable alternatives, especially for patients who are self pay. For instance, I often use GoodRx to help patients find discounts on medications as it can significantly lower the cost of medications. I also ensure that patients understand their medication regimen, but language barriers can make patient education a challenge. I rely on professional interpretations or translation services so that the patient and the family understands the entire treatment plan. And like you, I also monitor renal function and GFR very carefully to avoid worsening any chronic kidney conditions. And I take special care to educate patients about the potential side effects, particularly in those who may be on multiple medications like calcium channel blockers or CHF. It's important to provide clear and accessible instructions, especially when patients face financial and language barriers. So I make sure that they have written instructions and resources that they can refer to, helping improve the adherence and outcomes.
Okay, so these are all good thoughts and tips. Emily, what do you think are some practical steps providers can take to minimize polypharmacy risk in hypertension management?
I'll say it again. I think encouraging lifestyle, teaching patients how to adhere to a Mediterranean diet, encouraging daily exercise to what activity level the patient can tolerate would be the best place to start. Teaching patients about good kidney health, how to stay well hydrated, just lifestyle and education.
Right, right. Because it sounds like it pretty much boils down to some of those things, most of those things. And so, what advice would you give to new nurse practitioners or providers about balancing guideline directed therapy with minimizing unnecessary medications?
I'd say work with the patient. Don't just medicate them and send them out the door. I know we're all very busy and we all have a schedule to keep, but I think actually developing that relationship with your patient and working with them and having open communication would be the most beneficial.
Right, right. And do you have any last final thoughts on improving patient outcomes while managing hypertension polypharmacy?
Just no, this patient education. I think we need to, and then collaborating with and working with their specialists as well, so everybody's on the same page.
Yeah, I agree. I think sometimes the left hand doesn't talk to the right hand, and that's where patients can kind of be the victim in that instance. So, well, I don't know about you guys, but I feel better equipped to handle hypertension with preventing polypharmacy complications.
I know, me too. The entire conversation on polypharmacy was really useful. I feel like we've gained some practical insights that will definitely help us in our practice moving forward.
This is such a well needed conversation, especially amongst providers. So I really thoroughly enjoyed it.
Me too. And before we sign off, let's revisit some key points from today's discussion. We've discussed the challenges of polypharmacy, its impact on hypertension, and various strategies for better medication management. I think it's important to remember that communication between providers and patients are critical, especially like Emily said, patient education and preventive medicine, I think is really needs to be more focused on. And I agree that prescriptions can be a problem and that we try to throw meds at every single problem. So if the patient is in a facility and communication with nurses is the alternative, since they're the ones managing meds, then we need to educate them to make sure that they're monitoring for side effects or complications. Last but not least, thank you, Emily. A huge thank you for sharing your valuable perspective. And as we sign off, we would like to encourage you to share this podcast with anyone who may benefit from this information. And together we can raise awareness on issues such as polypharmacy, make patients happier, and support healthier practices. Thank you for joining us.
Thank you. Bye, Emily.
Bye.
Thank you.
Thank you.